So I apologize for not actually having a patient to do this assessment on. Um, it has been a very busy week and I haven't had any time to really get a hold of anybody to help or work with my classmate. That being said, I did write down my assessment and hopefully it's good enough and I can justify some of the reasons why I would do things I did in it. So that being said, I will jump right into it. Dispatch to a 26-year-old female with altered mental status. Friends called saying patient was not acting right and was very unsteady. Friends not very cooperative with dispatch. Upon arrival, assured the scene was safe. BSI was used, gloves, mask, and goggles or eye protection. Noted that needles were found in the residence. Also called to have PD stand by given the altered mental status. At this time, I also requested ALS because of the altered mental status, not sure if it was going to be a stroke or an advanced life support call. Patient found sitting on the floor in a tripod position, considered using the C-spine, but the way the patient was sitting, I opted against this. Patient appears pale and with shallow respirations. Patient responds to verbal stimuli. She did not note our presence into the room until we made contact with her verbally. Life threats are possible stroke, drug use, diabetic emergency, because there is the shallow breathing and the patient not cooperative with questions, so it's still unknown what this is going on. Lungs are clear, breathing is shallow and slow at 10 breaths a minute, pulse, ox. We put her on and she is approximately 94% at room air. No bleeding found, skin is cool, clammy, and pale. Heart rate is fast and strong. Patient is a priority transport for me. Decided to check blood glucose with a result of 40. Cincinnati stroke assessment was found. No negative findings to indicate that it might have been a stroke at this point. Pupils were equal, round, and reactive to light. CSMs were delayed on the extremities slightly, but nothing serious. Patient has a gag reflex and is able to take oral glucose. Her words are slightly incoherent. That could be due to the blood glucose level. Patient is placed into an ambulance at this time just to expedite the transport and placed on a monitor just in case, and an IV inserted in case fluids or medication need to be given. Vitals were taken at this time with a heart rate of 110. Oxygen was still 95% on room air. Blood pressure was 146/90, which is a little concerning for me. But given everything else going on, it's probably not the worst thing in the world. Respiration is still at 10, but after listening to the lung sounds and noting that they were clear, noting a equal rise in chest bilaterally, and the absence of any concerning lung sounds, which I didn't state earlier, sorry. I am not as concerned with this. I'm also going to forego oxygen for now because of the her oxygen saturation level. After a short time, the patient begins to respond. Recheck the blood glucose, and it shows 82. Patient is able to answer the history questions. No known allergies. She is on Humalog and Lantus. She is a type 1 diabetic. The last time she ate was 3 hours prior. She took her insulin after, but is unsure how much she actually took after eating, which leads me to believe that she probably took way too much insulin for what she ate. As far as the patient, she was not sure how long after eating she took the insulin, but the onset of these symptoms were 20 minutes prior to our being called. There's no provocation, no radiation of pain, no severity of pain. She's not in any pain, just kind of was confused. The patient was reassessed every 5 minutes at my behest for deterioration, and she was transferred to ALS care en route to the hospital. At this time, she was cooperative and responding appropriately, and that was after approximately 10 minutes. With this patient, the initial call made me think that the patient either could have been having a stroke, diabetic emergency, or drug overdose. The presence of syringes and the lack of cooperation from the friends inclined me more toward drugs. The diminished cooperation also made me suspect a stroke in conjunction with the diminished CSMs, or delayed. The blood glucose check confirmed in part that it was a diabetic emergency. Continual monitoring of the blood glucose while placing an IV and monitoring was done in such a case that the patient had two separate medical emergencies going on or occurring. Whether or not medications or fluids would have been administered via the IV is something that could have been handled later, but at least the IV was in place in case it was needed. The monitoring would have also have shown any potential cardiac events that may have been hidden on a primary assessment. And as an advanced, I would be thinking about this differently than as a EMT. As an EMT, I would have seen the blood glucose and been like, yep, that's our problem. We're just going to transport and they can figure it out later. Whereas as an advanced, ensuring that an IV was in place, even if it's just the port, ensuring the rapid transport, trying to perform more of those stroke scales after confirming that it was a low blood sugar. That way our patient is ready to go. Any life threats that may creep up after are taken care of, or at least able to be presented to the emergency department at the receiving facility so that they can appropriately and timely take care of any issues or initiate any protocols needed. With that being said, I think I am done. And thank you for the class. I have enjoyed it very much, even though I haven't participated very much. Thank you.